You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about management of mitral regurgitation. We'll start with management of chronic primary mitral regurgitation, then talk about management of chronic second-degree mitral regurgitation, and then we'll move on to talking about management of acute mitral regurgitation. In each section, we'll start with the medical management, then we'll talk about intervention, which includes surgical intervention and transcatheter intervention. Finally, we'll end with a section on post-mitral valve repair or replacement problems. So let's start with medical management of chronic primary mitral regurgitation. In chronic primary mitral regurgitation, there is no medical treatment that has been shown to slow progression towards surgical intervention. What do the 2020 AHA-ACC guidelines on the management of patients with valvular heart disease say about medical therapy for chronic primary mitral regurgitation? In symptomatic or asymptomatic patients with severe primary mitral regurgitation and LV systolic dysfunction, stages C2 and D, in whom surgery is not possible or must be delayed, GDMT for systolic dysfunction is reasonable, class 2A. So it's basically saying you should do HFrEF GDMT if there happens to be concomitant HFrEF. In asymptomatic patients with primary mitral regurgitation and normal LV systolic function, valve stages B and C1, vasodilator therapy is not indicated if the patient is normotensive, class 3, no benefit. So there's really not much to say in that section. How about intervention for chronic primary mitral regurgitation? First, you think about the feasibility of repair or replacement. Carpentier type 1, which is normal leaflet motion, is potentially repairable. If it's simply an enlarged annulus, it can be fixed with an annuloplasty without touching anything else. Type 2 Carpentier disease, which is increased leaflet mobility, is highly repairable. Type 3, which is decreased leaflet mobility, is difficult to repair. Replacement is needed for type 3. Pretty much all primary mitral regurgitation that is severe gets surgery, even if it is asymptomatic. It is just a matter of what the level of recommendation is. In severe primary mitral regurgitation, indications for mitral valve surgery are either symptoms or, if asymptomatic, you can still intervene if any of the four conditions are present. LVEF less than or equal to 60%, LV end-systolic diameter of at least 40 millimeters, new atrial fibrillation, or PA systolic pressure of more than 50 millimeters of mercury. So these are the four situations where you're allowed to intervene if the patient with severe primary mitral regurgitation is asymptomatic. Why do we care about LV end-systolic volume, LVESD? MR causes LV dilation, stressing the mitral apparatus, worsening regurgitant volumes, perpetually increasing LVESD. Chronic volume overload leads to irreversible LV dysfunction and poorer prognosis. The goal of MR intervention is to correct it before LV systolic function takes hold. Because if moderate LV dysfunction develops, prognosis will be worse even after mitral valve surgery. Since symptoms do not always coincide with LV dysfunction, serial imaging is needed. The ideal time for mitral valve surgery is when the LV is just approaching systolic dysfunction at an LVEF of 60%, LV end systolic diameter of 40 millimeters. Because the loading conditions in mitral regurgitation allow for continued late ejection into a lower impedance left atrium, the LV ejection fraction is artificially elevated, and a higher cutoff for normal LVEF is used at 60% in mitral regurgitation compared to the cutoffs used in other kinds of valve disease and heart failure. For LV function and size to return to normal after mitral valve repair, intervention has to occur when LVEF is more than 64% and LV end-systolic diameter is less than 37 millimeters. So if the LVEF has fallen to 60% or lower and LV end-systolic diameter has widened to 40 millimeters or more, there's no question this is a class 1 indication to intervene, even if the patient's asymptomatic. Normal LV end-systolic diameter is 40 millimeters or less in men and 35 millimeters or less in women. The LV end-systolic diameter that prompts referral to aortic valve replacement is 50 millimeters or more, whereas the LV end-systolic diameter that prompts mitral valve surgery in mitral regurgitation is an LVESD of at least 40 millimeters or more. Because primary mitral regurgitation is a mechanical problem of leaflet coaptation, it requires a mechanical solution. That's why there was barely anything to say in the section on medical management of chronic primary mitral regurgitation. Mitral valve repair is strongly favored over replacement in isolated severe primary mitral regurgitation that's limited to less than half of the posterior leaflet, such that annuloplasty and posterior leaflet repair are sufficient. Mitral valve replacement is inappropriate unless mitral valve repair has been attempted and was unsuccessful. Mitral valve repair is greatly preferred over mitral valve replacement because of preserved LV function, lower operative mortality rate, and lower rate of complications associated with prosthetic valves in the long term. The exception is that ischemic mitral regurgitation can go straight to mitral valve replacement instead of mitral valve repair. If the primary mitral valve disease is rheumatic, repair can be harder than for degenerative disease due to thickened and calcified leaflet and extensive subvalvular disease with chordal fusion and shortening that can be seen in rheumatic mitral valve disease. Mitral valve repair in rheumatic disease is limited to those with less advanced disease or those who cannot be adherent to anticoagulation for a mechanical mitral valve replacement. All of that was for severe primary MR. What about moderate primary MR? Moderate MR does not get surgery, but moderate AR, aortic regurgitation, is eligible to get intervention if they're getting other concomitant cardiac surgery. So once again, the current guidelines say that moderate mitral regurgitation does not qualify for surgery. Mitral valve repair should have a 95% success rate, a less than 1% operative mortality rate, a 95% freedom from operation, and more than 80% freedom from recurrent moderate or severe MR at 15 to 20 years, a long-term survival rate equivalent to age-matched general population. Now let's hear from the guidelines. What do the guidelines say about intervention for chronic primary MR? In symptomatic patients with severe primary MR, valve stage D, mitral valve intervention is recommended irrespective of LV systolic function. That is a class 1 recommendation. So again, that is for symptomatic patients with severe primary MR. No question. Now, how about asymptomatic patients? In asymptomatic patients with severe primary MR and LV systolic dysfunction, defined as LVEF of 60% or lower and LV end-systolic diameter of at least 40 millimeters, stage C2, mitral valve surgery is recommended. That's a class 1 recommendation. And again, note that EF is very high to qualify for mitral valve surgery. And for the LV end-systolic diameter, remember that normal is 40 millimeters or less in men and 35 millimeters or less in women, and the cutoff is 40 millimeters or more for giving mitral valve surgery. Next, in patients with severe primary mitral regurgitation for whom surgery is indicated, mitral valve repair is recommended in preference to mitral valve replacement when the anatomic cause of mitral regurgitation is degenerative disease if a successful and durable repair is possible. That's a class 1 recommendation. In asymptomatic patients with severe primary mitral regurgitation and normal LV systolic function, meaning LVEF of at least 60% or up, and LV end-systolic diameter that's within 40 millimeters or less, stage C1, Mitral valve repair is reasonable when the likelihood of a successful and durable repair without residual MR is more than 95% with an expected mortality rate of less than 1% when it can be performed at a primary or comprehensive valve center, Class 2A. In asymptomatic patients with severe primary MR and LV systolic function, with LVEF that's still above 60% and LV end-systolic diameter that's still within 40 millimeters, valve stage C1, but who have a progressive increase in LV size or decrease in EF on at least 3 serial imaging studies, mitral valve surgery can be considered irrespective of the probability of a successful and durable repair. That's a Class 2B recommendation. In severely symptomatic patients with NIHA Class 3 or 4 with severe primary MR and high or prohibitive surgical risk, transcatheter edge-to-edge repair or TEER is reasonable and mitral valve anatomy is favorable for the repair procedure and patient life expectancy is at least 1 year, Class 2A. In symptomatic patients with severe primary MR attributable to rheumatic valve disease, mitral valve repair can be considered at a comprehensive valve center by an experienced team when surgical treatment is indicated, if a durable and successful repair is likely, Class 2B. In patients with severe primary MR where leaflet pathology is limited to less than 1/2 the posterior leaflet, mitral valve replacement should not be performed unless mitral valve repair has been attempted at a primary or comprehensive valve center and was unsuccessful. Class 3 harm. Great, so now you have a good understanding of management of chronic primary mitral regurgitation, and we're going to move on to chronic secondary mitral regurgitation. Medical management. Since secondary mitral regurgitation typically develops as a result of LV systolic dysfunction, HFrEF GDMT, revascularization, ablation, and/or cardiac resynchronization therapy is a mainstay of therapy for improving survival and symptoms. As GDMT reduces LV volumes by reverse remodeling, GDMT reduces the severity of secondary MR. That's why there is a much stronger emphasis on GDMT and more applicable GDMT agents in secondary MR compared to primary MR. In chronic secondary MR, the leaflets and cords of the mitral valve are usually normal. The mitral regurgitation is instead caused by severe LV systolic dysfunction from either CAD or other idiopathic myocardial disease, whereby the normal and dilated LV causes displacement of the papillary muscle, in turn causing leaflet tethering and annular dilation that prevents adequate leaflet coaptation. Another way secondary MR can occur is by LA dilation, which occurs in patients with atrial fibrillation and other cardiomyopathies, which in turn dilates the mitral annulus and prevents adequate leaflet coaptation. Since mitral regurgitation is only one component and more of a consequence of the disease, restoring the competence of the mitral valve is not curative in secondary MR, unlike in primary MR. Therefore, it is especially important to undertake HFrEF GDMT revascularization, ablation, and/or cardiac resynchronization therapy in these patients for improving survival and symptoms. What do the 2020 valve disease guidelines say about medical therapy for chronic secondary MR? Patients with chronic severe secondary MR, valve stages C and D, and heart failure with reduced LV ejection fraction should receive standard GDMT for heart failure, including ACE/ARB/ARNI, beta blocker, MRA, and biventricular pacing as indicated, Class 1. In patients with chronic severe MR and heart failure with reduced LVEF, a cardiologist expert in the management of patients with heart failure and LV systolic dysfunction should be the primary multidisciplinary team member responsible for implementing and monitoring optimal GDMT, Class 1. If you're interested more in these GDMT agents, you're welcome to visit my website, www.gdmt.org. Now we'll talk about intervention for chronic secondary MR. Mitral valve surgery improves survival, symptoms, and quality of life in patients with severe secondary MR who have symptoms despite GDMT. Mitral valve surgery reduces chamber size and improves peak oxygen consumption. As for repair versus replacement, in a randomized trial, mitral valve repair versus replacement in severe secondary ischemic mitral regurgitation, there was no difference in survival or LV remodeling at 2 years, but there was a higher recurrence of moderate severe MR in the mitral valve repair arm than in the mitral valve replacement arm, leading to higher heart failure incidence and repeat hospitalization. Whereas in primary MR, mitral valve repair is favored over mitral valve replacement whenever possible. In secondary MR, mitral valve repair is less durable, so there is no strong preference for mitral valve repair over replacement. Secondary severe MR is only given mitral valve surgery if they are symptomatic. There's no indication for mitral valve surgery in asymptomatic severe secondary MR. Because in that situation, you really need to focus on the GDMT and other agents for controlling the secondary MR's cause. It is possible for chronic secondary MR to develop, even if LV ejection fraction is preserved, if there is progressive LA dilation, which leads to enlargement of the mitral annulus and malcoaptation of the leaflets. This may occur in patients with restrictive cardiomyopathy, non-obstructive hypertrophic cardiomyopathy, and atrial fibrillation. Successful ablation of AFib may reduce or eliminate the MR, so GDMT and ablation should be tried first. We only reluctantly pursue mitral valve surgery, class 2B, if GDMT and ablation won't work. In patients undergoing CABG for severe CAD who also happen to have secondary MR that is severe and asymptomatic, it is controversial whether or not to simultaneously do mitral valve surgery, as it does not improve survival. A sub-study of STITCH trial suggests that it may still be beneficial. For now, it has a 2A recommendation until further studies. The COAP trial showed that there's improved survival, hospitalization, symptoms, and quality of life from TEER, transcatheter edge-to-edge repair with MitraClip, versus GDMT for secondary MR. So as of the 2020 guidelines, the selection criteria for TEER or MitraClip are that of the COAP trial: LV ejection fraction 20 to 50%, LV end-systolic diameter of 70 millimeters or less, PASP of 70 millimeters mercury or less, and persistent symptoms, New York Heart Association class 2 to 4, despite GDMT. In the MITRA-FR trial, which included patients with much more dilated LVESD and LVEDD, it showed no benefit from TEER, which is why TEER has an LVESD cutoff for eligibility. The greater the reduction in mitral regurgitation severity from TEER, the greater the LV and LA reverse remodeling. All of that was for severe secondary MR. What about moderate secondary MR? Note again that moderate MR does not get surgery, whereas moderate aortic regurgitation is eligible if they're getting other cardiac surgery. Also note that while asymptomatic primary MR could get mitral valve surgery, asymptomatic secondary MR can only get surgery if getting a CABG. Now let's hear from the 2020 valve guidelines. What do they say about intervention for chronic secondary MR? In patients with chronic severe secondary MR related to LV systolic dysfunction, LVEF less than 50%, who have persistent symptoms, New York Heart Association class 2, 3, or 4, while on optimal GDMT for heart failure, stage D, TEER is reasonable in patients with appropriate anatomy as defined on TE, and with LVEF between 20 and 50%, LV end-systolic diameter of within 70 millimeters or less, and pulmonary artery systolic pressure within 70 millimeters of mercury or less, class 2A. In patients with severe secondary MR, valve stages C and D, mitral valve surgery is reasonable when CABG is undertaken for the treatment of myocardial ischemia, class 2A. In patients with severe chronic secondary MR, from atrial annular dilation with preserved LV systolic function, LVEF of 50% or more, who have severe persistent symptoms, New York Heart Association class 3 or 4, despite therapy for heart failure and therapy for the associated atrial fibrillation or other comorbidities, stage D, mitral valve surgery may be considered, class 2B. In patients with chronic severe MR related to LV systolic dysfunction, LVEF less than 50%, who have persistent severe symptoms, NIHA class 3 or 4, while an optimal GDMT for heart failure, stage D, mitral valve surgery may be considered class 2B. Note, by the way, that all of these EF recommendations in the recommendations for chronic secondary MR is 50%, whereas in chronic primary MR, all the EF cutoffs were 60%. Now, the next one is in patients with a CAD and chronic severe secondary MR related to systolic dysfunction, LVEF less than 50%, stage D, who are undergoing mitral valve surgery because of severe symptoms, New York Heart Association class 3 or 4 that persist despite GDMT for heart failure, chordal sparing mitral valve replacement may be reasonable to choose over downsized annuloplasty repair, class 2B. We have completed our discussion of chronic primary MR and chronic secondary MR. Now we'll move on to management of acute mitral regurgitation. Acute mitral regurgitation occurs when there is leaflet perforation, chordae tendineae rupture, or papillary muscle rupture, which can result from infective endocarditis, myxomatous mitral valve disease, or acute STEMI. Urgent mitral valve surgery, repair over replacement, is required. So the 2020 AHA-ACC valve guidelines does not even have a flowchart for this. All cases lead to prompt surgery. In terms of medical management for acute MR, use vasodilators to reduce the impedance in aortic flow in order to preferentially guide flow away from the LV to LA pathway into the LV to aorta pathway. The goal is to simultaneously increase forward output while decreasing the MR volume. This should be done with a sodium nitroprusside drip or nicardipine drip that is titratable. This might be limited by systemic hypotension. Consider using intra-aortic balloon pump counterpulsation to lower systolic aortic pressure, decrease LV afterload, thereby increasing forward output while decreasing the MR volume. Of course, you have to make sure that the patient does not have concomitant aortic regurgitation before you insert an IABP. Now, post-mitral valve repair problems. This is the last section in this episode. A TTE is done to establish a new baseline 6 to 12 weeks after the mitral valve intervention, as well as right after the mitral valve intervention before discharge. Once this baseline is established, routine TTE can be done at least 3 years from the valve repair or replacement. Okay, so time of discharge, 6 to 12 weeks after the mitral valve intervention, and 3 years after that. Systolic anterior motion of the mitral valve early after repair is quite common when the left ventricle is small and underfilled. The appropriate steps are to increase left ventricular preload, give IV fluids, decrease contractility, and decrease the afterload. With these steps, resolution of the SAM is common. The best pharmacological agent is the alpha agonist phenylephrine in an acute setting. Intravenous epinephrine or dopamine would be the incorrect choices that would likely exacerbate the SAM pathology in the post-op setting. Factors that predict the development of SAM post-mitral valve repair are mitral valve coaptation point to septal distance of less than 15 millimeters, anterior leaflet length greater than 35 millimeters, posterior leaflet length greater than 15 millimeters, small LVOT diameter. These are the factors that predict the development of SAM post-mitral valve repair. Because of their close anatomic proximity to the mitral valve, the non and left coronary aortic valve cusps are prone to injury during mitral valve surgery, which may result in cusp perforation during placement of annuloplasty sutures or cusp retraction from pull on the adjacent aortomitral curtain with secondary severe aortic regurgitation. The right coronary cusp is not prone to the same complication because it is furthest away from the mitral valve. Antibiotic prophylaxis for mitral valve prolapse is no longer recommended for MR based on current guidelines, but it is indicated after surgical repair or replacement of the mitral valve. If a patient develops ventricular fibrillation or a lateral STEMI immediately after mitral valve repair, the fact that they had a clean cath prior to the mitral valve repair should not be taken as reassurance that nothing needs to be done. iatrogenic coronary occlusion is the most likely cause, and immediate coronary angiography should be performed. This surgical complication is rare, but immediate recognition and management is essential. The left circumflex and posterior descending artery are in close proximity to the mitral valve. The coronary arteries can be as close as 1 millimeter to the mitral annulus. During mitral valve repair or replacement, surgically, sudden coronary occlusion can occur due to direct injury or distortion from the suturing and/or coronary embolization from bone, suture material, silicone, thrombus, or air embolism. Direct injury can occur for a variety of reasons, including but not limited to suturing around or through the artery leading to occlusion, distortion of the artery laceration, and subintimal hematoma. Severe mitral annular calcification, anomalous coronary anatomy, and use of large annuloplasty bands or rings may increase the risk of iatrogenic coronary occlusion. Coronary angiography should be performed immediately, which can help to determine the mechanism of coronary occlusion. We have now gone over medical management and intervention for chronic primary MR, medical management and intervention for chronic secondary MR, management of acute MR, and post-mitral valve repair or replacement problems. That's all for this episode, and this closes out our 3-episode series for mitral valve regurgitation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.